Welcome to the late-breaking clinical trial session. It's great to have you here. We have all our speakers here. We're going to, I think, have a really nice variety of topics to discuss. Drug dosing with cystatin C, sparsentan for FSGS, and then the diuretic comparison project, secondary analysis with kidney stones. And without further ado, the first speaker is Siwan Kaur, who's a nephrology fellow at MGH, and he's interested in onconephrology. This is the first fellow presentation, so I want to recognize the fellows who are here and thank you for covering for our patients. And thank you for being the future of nephrology. And I'm excited about this presentation. It's about redefining carboplatin dosage using the EGFR with the combined biomarker, creatinine and cystatin C, versus the Cockcroft Gold, which is often recommended in the package inserts, and the impact on platinum-associated adverse events. So, thank you.
All right, thank you, NKF and committee, for the opportunity today to present our group work. My name is Siwan Kaur. I'm currently a second-year general nephrology fellow at MGH in Boston. And today, my title of my abstract is Redefining Carboplatin Dosage Using CKD-EPI Combined Equation versus Cockcroft and Impact on Platinum-Associated Adverse Event. I have no disclosure. And here are the learning objectives for today. So for the background of this talk today, we'll be discussing the current evidence and literature on how to assess GFR in patients with cancer. Secondly, we'll identify how discrepancy between creatinine and cystatin C might help us identify patients who are at risk for developing chemo side effects. And lastly, we'll demonstrate how different GFR equations would actually impact chemo dosing. And I will finish off the talk with my abstract and results. So to start, why is accurate GFR assessment important in patients with cancer? So it directly impacts decision-making in terms of drug selection. For example, carboplatin dose is preferred over cisplatin when the patient have lower GFR. And drug dosing is actually pretty important, especially for renally clear medications. And with underdosing chemo drugs, you expect progression of disease and lead to undertreatment. On the other hand, if you overdose a patient using a inappropriate GFR equation, that will lead to toxicity. And most importantly, most oncological trial nowadays or in the past have pretty strict exclusion criteria, essentially ruling out any patients with low GFR, so depriving this group of patients with further treatment options. And with that, I would like to pose a question for the audience. Which of the following GFR estimating equation is most commonly used in cancer clinical trial? A, CKD-EPI 2021 creatinine. Second, CKD-EPI 2021 combined equation. CKD-EPI 2012 cystatin C. And CKD-EPI 2012 creatinine and MDRD. Just gonna wait a couple seconds here. Okay, so it looks like we got a pretty majority vote for Cockcroft. And the answer is Cockcroft. So talking about GFR estimation, right? So what are the options we have, So we saw kind of broadly categorize this into ways to estimate GFR using exogenous filtration marker, which is known as the gold standard. However, this is mainly used in research purposes and is pretty cumbersome and expensive. It's not commonly used in clinical practice. And on the other hand, in clinical practice, we normally use endogenous filtration marker, which are creatinine and cystatin C. And here are a couple equations that we normally use for estimation of GFR. And despite the introduction of new GFR equation over the couple years, like CKD-EPI, majority of oncological trials and centers still remain the use of Cockcroft creatinine clearance. So when interpreting GFR that utilizes creatinine and cystatin C, it's important to be aware of the non-GFR determinants. And with that, I would like to ask the audience the following question. So which of the following might affect cystatin C levels independent of GFR? You can select more than one option. Just a reminder, you can pick more than one option. You can pick all the options as well. Okay, so looks like corticosteroid use, inflammatory state, high adiposity are like the top three. So let's review the results. So the answer is B, C, D, and E. And I would like to highlight here is, looking at C, D, and E. These are pretty common characteristics that you normally see in cancer patients. So it's important that when you interpret cystatin C in cancer patients, all three of these factors might falsely elevate cystatin C. So as we all already know, both creatinine and cystatin C are affected by very different factors. But I would like to kind of highlight here is creatinine is highly affected by muscle mass, and this is especially true in patients with cancer. As their disease progresses, develop sarcopenia, and having low muscle mass might falsely lower the creatinine. So for example, having a creatinine of 0.9 doesn't mean the patient has a normal renal function. In fact, some patients might have some degree of renal dysfunction with 0.9 of creatinine. On the other hand, cystatin C is not influenced by muscle mass, but affected by adiposity. And again, just going to highlight here, inflammation and glucocorticoid use also might cause an elevation in cystatin C. So with all these like non-GFR determinants in mind, it can be really hard to interpret GFR. And this is why people are wondering, which equation you should trust, especially in this group of patients with cancer, which ultimately set off the first study that really answered some question at that time. And this was the OncoGFR study, which was published 3 years ago. It was the first study that actually compared performance of various GFR estimating equation using the measured GFR, which is the gold standard as a reference. So they included 1,200 patients with solid tumor, and here are the results. So let me kind of orientate you here. So bias is defined as measured GFR minus GFR calculated using the various equation. And accuracy is the percentage of patient with GFR more than 30% different from measured GFR. So from OncoGFR study, they found that Cocker-Graph creatinine clearance is the least accurate GFR estimating equation. And again, the Cocker-Graph and CKD epi creatinine tends to overestimate measured GFR. On the other spectrum, CKD epi cystatin C tends to underestimate GFR. And the best performing equation from the study was the CKD epi combined equation. And so obviously we know both cystatin C and creatinine have their own issue and limitations. And from this study, they highlighted that creatinine tends to overestimate GFR. You can see there's a line on the left side is overestimation, on the right side is underestimation. And most of the dots for creatinine falls on the left side. And this is especially true for patients with low BMI, lower GFR, metastatic disease, as well as a lower performance index. On the other spectrum, cystatin C tends to underestimate GFR, and most of the dots lies on the right side. And this tends to happen with patients with higher BMI, metastatic disease, and lower performance index. And on the far left corner is the graph or illustration about combining both cystatin C and creatinine. And that's all kind of pull all the dots towards the middle. giving us a less bias and better estimation of GFR. And moving forward after the study, actually a month ago, the Mayo Clinic group published another study. So this time they actually included hematological cancer patients, not just solid cancer patients. So what they did really validated the results from the OncoGFR study. And again, consistently it showed that Cocker-Graph was actually the equation that had performed the worst and prone to overestimate. The CKD-EPI-CSAN-C equation tends to underestimate. And the best equation in this study was actually the CKD-EPI combined equation. So looks like from these two studies, we know that the CKD-EPI combined equation might be the best tool we have to estimate GFR in patients with cancer. And this is actually further consolidated by a statement and consensus released by American Society of Onconephrology last year, when they recommend and suggest that when estimating GFR in patients with cancer, we should use validated GFR equation incorporating both CSAN-C and creatinine, and try to avoid use of non-validated equation, which includes the Cocker-Graph. So now that we have all these recommendations and consensus, despite that, in the oncology world is completely different. And what they have been mainly using up to today is still Cocker-Graph. So now I want to get back to why patients with cancer actually are so unique, and what our team has done in the past when we try to quantify sarcopenia, because it's a big part of why creatinine tends to overestimate GFR. In fact, we know that sarcopenia affects up to 60% of patients with advanced cancer, and with sarcopenia, we expect a lower muscle mass and falsely lower creatinine. And here's a diagram, a cross-section, a CT scan of two patients. In fact, on surface level, they might have the same BMI, but they very much have very different body composition. The diagram highlighted in red are muscle mass, and the green are like adipose tissue. And why do we care about body composition? So our group actually did a study which included around 500 patients with cancer, and we evaluated the relationship between different body composition and the discordance of eGFR based on CSAN-C versus creatinine. So we divided all these patients into 4 groups of body composition, and we found that the 2 groups with patients with sarcopenia actually show a higher percentage of patients with discordance in GFR. And the conclusion of our study was, both sarcopenia and high adiposity were actually independently associated with large discordance in GFR. So why do we care about discordance in GFR? So subsequently, our group did actually another study that involved 5,000 adults, healthy adults, elderly, and we followed them up in 2 years. And this is a nationally represented cohort. And what we did was we looked at how GFR discordance might affect their outcome. And what we observed was with increasing in age group, the prevalence of discordant GFR increases as well. And from this study, we showed that GFR discordance was found to be associated with poor outcomes. This included death, fall, hospitalization, and with higher degree of GFR discordance, you can see a steeper mortality curve as well. So from this study, we suggest that GFR discordance might actually possibly be a marker for frailty. So not only we know that GFR discordance is associated with poor outcome, but it also was shown to cause more medication side effects in patients with cancer. So this is actually the very first study done by our group a couple years ago, which we included 1,800 patients with cancer, when we look at exposure in terms of GFR discordance and the outcome. And based on this study, we see that patients with GFR discordance, when they are receiving renally clear medication, they tend to develop higher rate of medication side effects. These include supratherapeutic vancomycin levels, development of hyperkalemia when they receive Bactrim, as well as development of baclofen and digoxin toxicity. So we have talked a lot now, so just a brief recap about what we have learned so far. We know that Cockcroft is probably not a good equation to use, despite that it's still commonly used in oncological world. And the most accurate and best performing GFR equation is CKD-EPI combined equation. We know that sarcopenia and high adiposity were associated with large GFR discordance, and having a large GFR discordance is associated with poor outcomes in elderly, as well as more medication side effects in cancer patients. So with all this in mind, how can we translate all this knowledge into chemo dosing? And now I'd like to kind of demonstrate how GFR would affect chemo dosing in real life. So we have a 77-year-old male here with invasive bladder cancer. And here we have a list of various GFR equations. We've calculated eGFR. And when we calculate carboplatin dosing, we utilize the covered equations, which is AUC times GFR plus 25. So the dosage actually is highly dependent on the GFR of the patients. So now we take, let's say, an AUC 5 as a dose. We plug in a number using Cockcroft, which most oncological centers use. This gives us a dose of close to 500 milligrams. And now we're going to plug a number using the measured GFR, which is the gold standard. And this gives us around 325 milligrams. And this is actually 50% higher than the dose actually indicated by measured GFR. And what you're seeing here is actually just one dose of chemo the patient is receiving. And you expect patient get multiple cycles of chemo, and they're going to develop side effects with cumulative accumulation of chemo dosing. And this was actually what led us to our work. And now I'd like to bring us back to my abstract today in redefining carboplatin dosing using the CKD-EPI combined equation versus Cockcroft and impact on platinum-associated adverse event. So our study aim includes determine how carboplatin dosing would be impacted by replacing the Cockcroft creatinine clearance with CKD combined equation. Also, we try to determine the association between receiving a carboplatin dose more than 15% higher than the dose indicated using the combined equation and development of platinum-associated side effects. Lastly, we also try to determine the association between discrepancy of serum creatinine and cystatin C and adverse event in patients receiving cisplatin and carboplatin. So here are the study methods. This was a prospective study. We recruited 441 adult patients who begin carboplatin and cisplatin treatment for cancer MGH. And this was done between 2023 and 2025. We exclude patients who receive any platinum-based chemo for the last 5 years, and any patients who receive carboplatin and cisplatin in the inpatient setting. And obviously, we exclude any patients without any baseline serum creatinine. In terms of data collection, what we did was we measured the serum creatinine and cystatin C simultaneously prior to the first dose of chemo, which includes either carboplatin or cisplatin. And cystatin C was added on as just for research purposes, and the results actually not showing up on the chart, and it's not available to the treatment team. Next, we compare the carboplatin dosing administered, which is calculated using the Cockcroft versus the dose calculated using the combined CKD-EPI equations. So we define the excess dose as a patient who received carboplatin dose more than 15% higher than the dose predicted by the combined CKD-EPI equation. And underdose is defined as those patients who receive a carboplatin dose more than 50% lower than the dose indicated by the combined equation. In terms of outcomes, our primary outcomes include platinum-associated adverse event within 90 days of chemo. This includes cytopenia, AKI, hospitalization, and the secondary outcome, we look at mortality within 90 days. And we utilize this fine-grained subdistribution hazard model, as well as Cox proportional hazard model to analyze our data. And here are the baseline characteristics for our cohort. So the mean age for our cohort was around 66 years old. 2/3 of patients are female, with majority being white. The two most common primary cancer were thoracic and gynecology. Majority of our patient actually had pretty advanced cancer, up to 70%. And the baseline GFR based on echograph was around 89, and based on the CKD-EPI equation was 82. So here are the results. So here is a histogram of the carboplatin dosing for our cohort of patients. So one thing to highlight here is that we did not see just overdosing. In fact, there's some patient actually underdose. So utilizing the CKD-EPI combined equation would have led to significant dose adjustment in around a quarter of the patients. And on the right side, around 12% of patients were actually defined as getting excess carboplatin dosing. And on the left side, 14% of patients were actually underdosed by our definition of exposure. And all the patients who falls in the middle technically receive a dose that we define as, within the 15% dose predicted using the combined GFR equation. And now you might actually ask me why, why do we pick 15% as a cutoff? So actually, there's no data currently that really guide us in terms of what's the threshold or cutoff for developing like adverse event. And now I'm going to show you a Lowe's plot when we look at several adverse event, the unadjusted relationship across several adverse event. Although it might be different for every adverse event, but looks like 15% seems to be the common ground when we see a rise in incidence of adverse event, and which is why we went with 15%. And here I'd like to present our results on our primary and secondary outcome. So the definition of adverse event were based on the CTCAE criteria, which is also, known as the common terminology criteria for adverse event by NIH. So from our study, we found that patients who receive an excess carboplatin dose were associated with increased risk of developing grade 2 and grade 3 anemia with a hazard ratio of 2 and 3 respectively. We also see the same effect for thrombocytopenia with a slightly higher hazard ratio. And also this group of patients are more likely to develop high-grade AKI with a staggering hazard ratio of 6.5. That means these patients are 6.5 times more likely to develop AKI. And in terms of hospitalizations, although we don't really see any statistically significance for that, but the hazard ratio is actually more than 1. And hopefully with bigger sample size that we are enrolling patient now, we should see a change in statistically significance. And lastly, patients who receive carboplatin overdose have actually 3 times higher risk for death in 90 days. And now I'm going to show you some data from the same cohort that my colleague, Dr. Liu, should be presenting during a poster session today because they are related to our finding. So feel free to drop by and learn more about our study. So for our study, for my study, we only look at carboplatin patients, but for the overall cohort, we actually included both carboplatin and cisplatin patients. And what we saw that, having a discrepancy in creatinine and cystatin C with a ratio of less than 0.7 was actually a risk factor for developing anemia, thrombocytopenia, high-grade AKI, as well as hospitalization. So based on this, we can sort of say that discrepancy in serum creatinine and cystatin C with a ratio of less than 0.7 can be seen as a predictor for adverse events, regardless of the dosing of your carboplatin and cisplatin. We also see the same effect on mortality. Patients are more likely to die in 90 days, and this suggests that discrepancy in cystatin C and creatinine is actually a strong predictor of death, and our hazard ratio was 6.6. And here are the limitations of our study. So this is a single-center study with mostly white population. We have a limited sample size, but enrollment is ongoing. In fact, we are sort of close to double the sample size that we presented on this abstract now. We do not have measured GFR as a reference, which is supposed to be the gold standard. And what we're showing here are only association and not causation. So there's a need for further clinical trial. So in conclusion, using the CKD-EPI combined equation to dose carboplatin, we have led to a quarter of the patients changes in their dose. Adverse events were more commonly seen and severe in patients who receive an excess carboplatin dose in our cohort. For future directions, utilization of CKD-EPI combined equations might help us identify patients who could benefit from a dose reduction to prevent adverse event. And hopefully in the future, we might have improved accessibility as well as availability for measured GFR. And with that, I'd like to thank the people who made this project possible, and especially my mentor, Dr. Megan Size. Thank you for listening. And now I conclude my presentation. I'm happy to take any question.
So I think we have time for maybe 2 quick questions. I will combine a few questions from the Q&A in the app. So one question is, the eGFR results are adjusted for body surface area 1.73 meters squared. Why did you not individualize the body surface area for the patient involved?
Yeah, so I think I might have shown in my slides the baseline characteristics of the demographics. So for the CKD-EPI combined equation, we actually dose it. We actually, on index, it means we actually adjusted that according to the patient's body surface area.
Okay, and then if there are no questions in the room, there's another question. When you say this only shows association, not causation, would you suggest randomizing patients to CG versus CKD-EPI creatinine?
I think that in an ideal world, in clinical trials, that's what we expect to do. But what we're doing now is more like a prospective study. So hopefully, with more convincing data, we can translate this into further clinical trial in the future.
Great. So that was C1 core, that is redefining carboplatin dosage using eGFR, creatinine, cystatin C, versus Cockcroft-Gault. Thank you so much. Okay, so next up, we have a presentation on FSGS from James Tumlin. He is a founder and CEO of NephroNet, a clinical trials group. He's a professor of medicine at Emory, and this is going to be patients in the DUPLEX trial that achieve partial or complete remission of proteinuria earlier and more often with sparsentan versus irbesartan. Implications for slowing progression of kidney failure in FSGS.
So I want to thank the NKF organizing committee for allowing me to present this really great data that I think you'll enjoy. And so we're going to talk about the DUPLEX trial and the efficacy of sparsentan, to remind the audience, which is a dual endothelin alpha and AT1 receptor antagonist, and its effects on proteinuria and slowing progression of renal disease in FSGS. So let's see, it should go next. Let's see. Okay, so these are my disclosures. I work with a lot of companies, including sparsentan and the Travere group, and so I do consulting work and grant work with them as well. So here's our learning objectives. We want to talk and get the audience used to thinking about endothelin-1 and Ang-2 and the rise of both these incredibly important hormones and its effects on glomerular function and ultimately downstream of the development of proteinuria. And what we're going to talk about is the effects of both these agents, endothelin-1 and Ang-2, on podocyte damage, and that includes podocyte apoptosis, release from the basement membrane detachment, development of proteinuria, and ultimately disease progression. We're also going to talk about the link between the proteinuria reduction and outcomes in GFR and renal survival in FSGS. So this is analogous to what you've seen going on in the IgA world. It's now being applied in the FSGS world, and a good development in my opinion. We're going to review the DUPLEX trial data, which is quite interesting, looking at sparsentan's effectiveness in reducing proteinuria in FSGS patients. And then ultimately, we're going to talk about the safety and efficacy of this new class of drugs. Okay, so this audience does not need any introduction. You know that FSGS, this is a description. It's what our renal pathology people describe on the biopsy, and the last time I counted the number, there were over 25 different diseases that can impinge upon the development of FSGS, including our old friend diabetic nephropathy, which is a form of FSGS. And so, but what we do know is that when people develop this, depending on how you slice the data, there can be up to a 40% reduction to ESRD within 10 years, 60% by 20 years, a really poor prognosis in this class of disease. And I think we forget about this. So if somebody is in your office and they're walking around with 30 or 40 pounds of edema in their legs, this is a physical impairment to them. It's a real issue. It contributes to sleeping disorders and a number of other things. And also the idea that there's an emotional burden with this. This idea that you have, for lack of a better term, the sword of Damocles coming down on you. Eventually you're going to wind up on dialysis. That's a lot for people. And not to mention, treating this disorder can be a financial burden for a lot of folks. Now, in primary FSGS, as we know, so in the days when most of us were training as fellows, the party line was to do a mg per kg of prednisone a day for a minimum of 16 weeks. Quite frankly, I gave that up a long time ago because of the horrific morbidity that came, particularly in the African-American community. And then, like a lot of people, I kind of switched over to the CNIs. And the CNIs, tacrolimus and cyclosporin, they definitely work. But the problem is, of course, as soon as you stop the drug, 80% come back with a recurrence of their disease. And leaving them long-term leads to nephrotoxicity. Now, genetic FSGS was, for the longest time, handled by our pediatric nephrology colleagues until the world of APOL1 came on. And so now it's an exciting new division or branch in the road, if you will. And I think a lot of people are going to be broken down into either APOL1 positive or negative disease, but there's still a lot of APOL1 negative FSGS things, and further testing will be coming. The unidentified FSGS group, in my personal experience, most of the time that's genitourinary. It's a person with undiagnosed vesicoureteral reflux or recurrent episodes of pyelonephritis, and they can develop high-grade proteinuria. I have a number of patients like that. Secondary FSGS, that would include sickle cell disease and drug-induced, including pamidronate and other drugs. Now, in children, the immunosuppressive, they tend to be a little bit more responsive, but even in that population, the response rate at best is 47%, and in adults, it's even worse. It's about 38%. So what this slide really tells us, the broad base of FSGS, that we don't know an awful lot about the disease, and we really don't have a lot of options to treat these people. Now, this is a pathophys slide to sort of tie together endothelin-1 and Ang2. And I'm going to show you a slide in just a minute that both these agents actually go up in response to FSGS injury. Now, endothelin-1, many people are familiar with, but what they don't know is that mole for mole, it is more potent than Ang2. And equally as important, if not more so, its effects last significantly longer than Ang2. Ang2 is more short-term, endothelin is more long-term. Both of these agents, when they bind to the podocyte, they stimulate a pathway that leads to podocyte apoptosis. They disrupt podocyte adhesion molecules, causing detachment, and they also impair glomerular filtration function primarily through disruption of synaptopotocin and related proteins. So when that happens and that podocyte either dies or detaches, that exposed basement membrane is allowed to attach to Bowman space. That becomes the nidus of most focal segmental lesions. And so as this process occurs, you have more podocyte detachment, more cell death, more adhesions, a progressive proteinuria, and a loss of podocyte density, and eventually progression toward end-stage renal disease. It's a vicious cycle that's played out over many months and years. This is a little bit better, more detailed description. So on the left here is a diagram of, here's our endothelial space here. Here's the endothelial cells, basement membrane, and our old friend, the podocyte. So when endothelin alpha comes in and binds specifically to the alpha receptor, when endothelin binds to the alpha receptor, this is where all the damage occurs. Endothelin beta and alpha are yins and yangs. So alpha beta is actually anti-fibrotic and hypotensive. Endothelin alpha is pro-fibrotic and hypertensive. Again, more so than even Ang2. Ang2 binds to the AT1 receptor, and one of the things that happens that's not well appreciated is that ETA alpha stimulation stimulates heparinase. And heparinase then degrades your glycocalyx, and so you lose one of the first electrostatic barriers to proteinuria. That's part of the whole process. Then it goes in, binds to the podocyte, and stimulates, as I mentioned a moment ago, two separate pathways of apoptosis, stimulates dysfunction of the podocyte footplate processes, primarily through synaptopotocin, and then detachment and cell death. Sparsentan, with its ability to block both the ETA alpha receptor and the AT1, disrupts this process at the receptor level. And hopefully what you're seeing would be a generalized podocyte protective. I think a lot of nephrology in the GN world is looking at what can we do to protect the podocyte. And so this process, sparsentan, helps that. It's anti-proteinuric and it's also anti-fibrotic. Now, one logical question is, if I'm going to give a drug that blocks the alpha receptor, is that an issue in FSGS? Well, it is. So this is a nice paper published about 3 years ago looking at a biopsy of a normal individual versus a patient with FSGS. It's a simple immunohistochemical staining for the endothelin alpha receptor. And you see basically no expression in the normal control. But in the patient with FSGS, you can see that it's lining Bowman's capsule, it's in the mesangium, and it's in the intercapillary cells, a tremendous upregulation of the ETA alpha receptor. And if you look at the histogram on the right, that increase is almost fivefold. So what that says is that this is a legitimate target for blocking this pathway and the downstream effects of podocyte loss and fibrosis. Okay, so proteinuria reduction, how important is this? It's very important. Okay, so many of y'all are aware at the last ASM meeting in San Diego last September was the PARASOL study. And if you're not familiar with this, is a registry put together of 1,626 patients with biopsy-proven FSGS that had over 1.5 grams of protein and GFR above 30. And they collected this from a number of different registries, Neptune, the Cure GN, the Chapel Hill group, and the Toronto registries and a number of others to pull together this coalition, which they put in the all cohort part. They broke the data down to those that had a biopsy of less than 6 months and what they referred to as the prevalent cohort of more than 6 months, and then asked a very simple question. If irrespective of the therapy in those patients in the registry, if they got to a GFR protein of less than 300, what happened to their progressive on the forward of time? And so then they followed these patients out to a total of 84 months. Now, if you met the target, again, irrespective of therapy, to less than 300, at the end of the 84 months, you had less than a 10% chance of progressing to end-stage renal disease. If you were at 500 milligrams, the number may be a little bit higher, but more or less the same, still about 10%. But then as you would predict, when you get above 500 to 1.5 grams, that rate went up to 15%. And if you had consistent proteinuria above 1.5 grams, you had a 30% chance of progression. Now, the real power, I think, of the PARASOL data is it showed that the proteinuria endpoints were consistent and much tighter, allowing us to correlate change in proteinuria with outcomes in GFR. When they did the same analysis, looked at change in GFR, the GFR, as you would predict, frankly, more variable, and the result was that they had less predictive ability, and the implications of that from a trial standpoint is that you needed much more patients to be able to see a difference. So again, this is pointing in the direction of what was seen in other forms of glomerular disease, and I think very encouraging. Now, what then the authors did, they took the PARASOL data and they backed it out a little bit and put down to a cutoff of 700 milligrams. And either you hit 700 milligrams or you didn't. And then if you did, at the 84 months, and again, like I said, 700 milligrams, you had about a 10%, maybe 15% chance of progression over the 84 months. If you did not achieve less than 700, your progression rate was near 40%. Then they compared that data to the RaDaR data from the UK, which was a multi-disease state, but they looked only at the FSGS patients, again 700 milligrams, and I would submit to you that those two curves are virtually superimposable. So on two separate databases across the Atlantic Ocean, you can see a very similar outcome between the two of these. I think that's very tight. Now, Okay, so now we're going to talk about a specific therapy, unlike the parasols. We're going to look at sparsentan in both the DUET and the DUPLEX trials. Okay, the DUET study, many of you probably seen this data. This is a phase 2B study, and they wanted to find out what was the dose, the optimal dose for sparsentan, and they compared it against irbesartan at 300 milligrams. So everybody got about a 2-week washout, and they had to have biopsy-proven FSGS. They allowed children into this, age 18 to 17, and then you had to have protein above a gram and a GFR above 30, and you were allowed to have prior immunosuppressive therapy. So everybody got in a double-blind trial for 8 weeks, 200, 400, or 800 milligrams of sparsentan versus the comparator control of irbesartan. At the end of the 8 weeks, they were put back on their assigned dose of sparsentan and followed again to the end of the study here on the right. The first thing to remember, at the end of the study, a full 43% of the patients achieved complete remission. And that's less than 300 milligrams for 24 hours. Pretty tight number. Now, what happened if you achieved that? If you got that number of less than 300, then your GFR rate decline over the follow-up of the study was negative 1.31 mils per minute per year. If you did not achieve that number, that decline rate went up to 7.6, so almost a 5-fold increase in decline in GFR. And when you amortize that data out and look at the rate toward progression in dialysis, it has a tremendous effect. When you then look at renal replacement therapy, ESRD, if you were a responder, it's 6.5%, 14.5% if you didn't respond. A 40% reduction in GFR, 22% versus 35%, and then an all combination endpoint, 21.7 versus 37.1. So a significant improvement in the long-term outcome based on a study done that parallels the Parasol study. Now, this is the DUPLEX study. So obviously this data was very encouraging. So they did a phase 3 trial. They landed on treating patients with 400 milligrams of sparsentan, again to the comparator of irbesartan at 300. Standard washout period. Children were still allowed in the study. And here's the breakdown. So roughly 10% of both wings of the study were kids in the study. FSGS had to be proven. They raised the GFR, the protein, up to 1.5 grams. The GFR stayed at 30. And then they did a full 2 years of blinded study. So you were on 400 or 300 of irbesartan, and then they weaned you off the RAS, and you were done. So one thing to remember here is, like some studies in the past, this was rigorously done. And they had a full 90% of the patients achieve complete RAS inhibition or Spartan gold dosaging. So the study indicates that, in fact, the patients took the pills and you could rely upon the outcomes based on compliance and execution of the trial. So then again, they cut the study off at week 108 and then a follow-up out to 112. Here's the demographics, standard stuff, low 40s. Male sex is about 55%. GFR was pretty well spared in the low 60s. Protein was substantial, near nephrotic range, 3.1 and 3.0 respectively. Some patients, there were some genetics, some APOL1s, and maybe 5%, and roughly a quarter of the patients had had prior immunosuppressive therapy coming in the trial. Here's the money end of it. So at the end of 108 weeks, if you were randomized to the sparsentan group, you had a drop in proteinuria by 50%, compared to 32.3% in the irbesartan group. An interim analysis done at 96 weeks showed a benefit with a partial remission, and I'll come back to that in just a second. And again, to emphasize, at the end of 180 weeks, so the addition of endothelin alpha blockade on top of standard full-on RAS blockade went from 32% up to 50% inhibition of proteinuria. Kidney failure. So they defined this if your GFR dropped to less than 15 mils per minute. So at the end of the 108 weeks, 6.5% in the sparsentan group versus basically a doubling to 11.2% in the irbesartan group reached renal failure. If you then looked at a 40% reduction in GFR, it was 21 and 23, a little tighter. Above 50%, 11.4%, and 16%, again at the end of 108 weeks. Okay, now, achieving proteinuria, what's the outcome of this? That of a partial remission, So again, just to reorient you, a partial remission was defined in this study as less than 1.5 grams with a minimum of a 40% reduction from baseline. Complete remission we've already talked about. Kidney failure we've already talked about. And so first thing to point out, this is the patient receiving a partial remission out to 108 weeks. The effect goes rapidly. And you'd sort of expect that with this drug, right? So in the first 12, roughly 13 weeks, there was a roughly 50% reduction in proteinuria compared to the irbesartan, and this difference stayed stable out through the entire 108 weeks of the trial. So at the end of the 100 weeks, 64% achieved partial remission versus 43% in the irbesartan group. But this next slide I think is really interesting. So this is complete remission. So these are the people that got to 300. And what they found was, once again, early in 12 weeks, there was a separation between the curves. But I would propose that this is a steeper curve compared to the irbesartan. And at the end of the 108 weeks, 2.5-fold higher patients in the sparsentan group versus the irbesartan had achieved complete remission. So that number is 18.5% versus 7.5%, 2.5-fold. And this is, I think, also very important. If you look at the patients that achieved partial remission in the trial, your chance of progressing to renal failure was only 3%, even in the partial remission group. If you were in the complete remission, it was 2.1% compared to 15.9 and 9.9. So what that says to me is that even a partial remission benefits the patient. Ideally, we want to get people to less than 300, but there's benefit at even attempting to get a partial remission. Side effects, fluid retention was a big concern for a lot of people. They were equal between both groups. Hypotension was maybe just a little bit higher in the sparsentan group. Acute kidney injury was equivalent. And the big one that most people were worried about, there was no heart failure in either group with this study. So in conclusions, we have a new arrow in the quiver, I think. So this is dual endothelin alpha receptor blockade with AT1 blockade through sparsentan led to a complete partial remission rates earlier and more often than patients receiving irbesartan blockade. The data is consistent with the findings of the PARASOL group, which again, remember, was naive to treatment. So with sparsentan, the data paralleled very nicely. Sparsentan was well tolerated over 108 weeks. Taken together, this supports that the antiproteinuric effect of the DUPLEX trial may be a new way that we have a way to protect the kidneys in FSGS. But I think I got a question for you. Yeah, I do. Okay. All right, so y'all had to pull up something, either your phone or whatever. Okay, so FSGS receiving sparsentan are blank, likely to reach complete remission of proteinuria, and therefore are blank, likely to progress to kidney failure, and there are your choices. Do we have it? I can give the answer. Well, see, I mean, sorry, you know, so you were more likely, the data showed more likely, oop, that was me, sorry. Thanks for letting me speak to you. I really enjoyed doing it and hope to hear some questions from you. Thank you very much.
That's great. This session is open for questions. Why don't you step up to the microphone, please?
Hi, that was a great rapid presentation, and the PARASOL meeting was really just an A+ event in medicine.
It was.
That somebody should give it a gigantic award. My question is, are there other things in the pipeline that are coming down now for FSGS also? What should we be on the lookout for?
Yes, there are. So atrasentan is a selective endothelin alpha receptor antagonist that does not have AT1 blockade. There is a CCRX AT1 compound that's under development for this. And there are other drugs that are being looked at in the fibrosis and FSGS realm, including certain complement inhibitors, and there's discussions about avacopan and things like that. So people are looking at this and saying, wow, what do we have in our armamentarium that we could apply to this really important problem?
So Thank you. A few questions about side effects. So
Yeah.
there are 4 FDA-approved drugs, I think, for IgA nephropathy and none for FSGS as far as I know. Sparsentan is approved for IgA nephropathy, and
Correct.
it has a REMS risk evaluation mitigation strategy for liver enzyme elevation. And I noticed that you didn't have any safety signal there. Any comments on that, or are you looking at that further?
Yeah, so when that came out, it was because, actually, when you look at the original study, there was really 2 patients in the sparsentan wing and 3 in the control wing that had the elevation of LFTs. And from my standpoint, I wasn't sure why the REMS came about. I can tell you I've given an awful lot of sparsentan over the last 2 years. I've never seen a signal with that. My understanding is that the FDA is looking at that. There may be a closure of that sometime in the fall. Please don't quote me on that. I think that's just an inside thought. So the thing that most people were concerned about was an offshoot of the SONAR trial, which many of you remember, which was atrasentan, and that there was an inordinate number of patients who developed congestive heart failure with that study. And so I think that the sparsentan people have done a good job trying to address that. And as you saw from this data, there was no heart failure in either one of the wings of the 2 groups. And so I just think it's not going to be an issue.
And speaking of heart failure, there's a question from the app about heart failure asking if you obtain transthoracic echocardiograms in patients randomized.
No, not that I'm aware of. No, they have not done that.
Okay, so there was no surveillance for that. There's also a question from the app about the selection of dose of sparsentan, 400 versus 800 milligrams. Do you have any comments on that?
Well, I was not part of that decision tree, so I don't. I can tell you that I have personally given high-dose sparsentan to a couple patients. One did have a bump in the LFTs and one did not. And so I don't know where that was a decision made by the Travere people. I'm not sure how that was arrived at.
Okay.
Uh-oh, I think someone's got an
There's a
answer.
question.
Maybe it's an answer or another question.
Hi, thank you so much for your lecture. Really nice to have more arsenal to help our patients. So my question is more regarding the type of patients that you recruited. What was the % of people with truly nephrotic syndrome, low albumins? And the reason why I'm asking that is that I understood you used people who were naive of treatment, right? So this is they were randomized to irbesartan versus, but I'm worried about these more nephrotic patients that may have immunological mechanisms, anti-nephrin, that is circulate, and they may benefit from immunological treatment, right? So I think selecting a treatment tailored only on proteinuria is not good enough, right?
So you're going to get me kind of on my soapbox about that. So, I mean, I think that there's a lot of we don't really have solid definitions of primary versus secondary. There's some people who believe that you have to have an albumin below 3.2. I personally don't agree with that. And to your point, is a person with 10, 11 grams going to be as responsive to this as somebody with 1,500 milligrams? Probably not. And to your point, that's somebody I think that all of us would consider some concomitant, probably yet to be developed, immunosuppressive therapy that goes along with that. So the answer to your question is this included about 75% were immunologic naive and about a quarter had prior immunosuppressive therapy. For me personally, I said this on the podium, I just don't give prednisone. I just don't do it. And I still am a believer in CNIs, but the same problem. So now the question that will drop out of that is, gosh, would a CNI with an ATA blocker like this be additive or beneficial? I think that's a decent question.
There's another question from the app about the use of sparsentan for diabetic nephropathy, theoretically, and I guess you spoke about atrasentan, but do you have any comments on that? Or
whoever you asked that question, thank you. Yeah, I absolutely believe that. So, and I say this openly to all the companies. Do I think that endothelin is a specific IgA disease? I do not. Do I think it's an FSGS? I do not. It's a CKD phenomenon. And I think that we really ought to consider, I think this is why this drug is so important, because this is yet another, so we all were taught, right, the three-legged stool of CKD management, ACE, ARB, and MRAs, and diuretics. Well, there's a fourth leg to the stool now, in my opinion, and that's endothelin. And I have tried through insurance companies to give this to my high-grade diabetics. I've been shot down every time. But eventually, I think we do need to study this in diabetics. I get it. The SONAR trial put a pale on everything. I get it. But I still think it's an important question we should address. Thank you, whoever asked that. No more questions? Come on. Speak up, sir.
I'm just saying it worked in SONAR. SONAR was positive.
I agree with you. Yeah, I totally agree. And it was the heart failure thing. What could they do? I mean, they had to abide by the Data Safety Monitoring Committee. It's just the way it is. But I think it's time for us to be reasonable and to look at this broadly, going back as a viable pathway of CKD management.
Can you talk about plans for publication or the FDA process at all?
They have not spoken to me about that. I don't know what that means.
Okay.
It may mean a lot.
Okay.
You're not on those paper, Tumlin. I don't know.
Okay, I just thought I would ask. Any other questions? So thank you for an engaging
Yeah, that was
presentation.
fun. Thanks very much.
Yes.
Yeah.
Duplex. Next up, we have kind of an encore presentation, I guess. It's fair to say. So Arif Ashani is the director of the primary care and the specialty service line at the VA in Minneapolis. And just a shout out for everyone who takes care of veterans in the United States and anyone who works at a VA hospital. I know this is a challenging time for you, so thank you for your leadership. And he, for many years, has directed large data sets and clinical trials looking at both acute and chronic kidney disease. And we heard about the diuretic comparison project, chlorthalidone versus HCTZ. The primary outcome from the original study was negative for cardiovascular events. Last year, we heard about CKD onset, which really there was no difference between the two arms, except for hypokalemia was more common in the chlorthalidone arm. And actually, we had a question from the audience last year about kidney stones. So here we are with a secondary analysis, and it's great to hear chlorthalidone compared to hydrochlorothiazide for the prevention of kidney stones, a secondary analysis from the diuretic comparison project. So let's see if this will work. Looks good. And without further ado, thank you so much.
Thank you very much to the NKF for again inviting me a second time to present results from the diuretic comparison project. So as you just heard, this is our analysis looking at kidney stones in this population that's predominantly treated for hypertension. I have no disclosures. So the learning objectives is to describe the impact of chlorthalidone on kidney stones as compared to hydrochlorothiazide, overall and by baseline history of kidney stones, and to describe adverse effects of chlorthalidone compared to hydrochlorothiazide for the kidney stone population. My co-authors, lots of people to thank. So why do we look at this? So as many of you are aware, the prevalence of kidney stones has been increasing. So if you look at N. Haynes from 1976 to 1980, the prevalence was about 3.2%. And if you go forward in time to the 2015 N. Haynes exam, the prevalence had increased to about 10%. As you all know, most of these kidney stones, so about 80%, are composed of calcium oxalate. And kidney stones are a chronic problem. Once you get one, untreated recurrence ranges from 20 to 50% at 5 years. So if we look at current guidelines for the prevention of recurrence for particularly calcium-based kidney stones, they recommend a thiazide diuretic. And they're silent on the type of thiazide diuretic that you should be using. If you look at a recent meta-analysis, it suggested that long-acting thiazide diuretics are more effective, so it's chlorthalidone and indapamide, compared to shorter-acting agents such as hydrochlorothiazide. Similarly, there was a retrospective study where they looked at 24-hour urine collections, and they compared chlorthalidone, so the longer-acting agents, to the shorter-acting agents, such as hydrochlorothiazide. And chlorthalidone was associated with a greater reduction in 24-hour urine calcium compared to hydrochlorothiazide. So it portends the question, is one better than the other? We happened to randomize individuals to chlorthalidone or hydrochlorothiazide, and we thought this would be a good opportunity to do a sub-study on this to identify if kidney stones were more common in one group versus the other. And so this is the question here. So the original diuretic comparison project, we went for 2.4 years. What we did was we extended the duration of follow-up, so to December 31st, 2023. So we now have an average duration of follow-up of 4.2 years to accrue a greater number of events. And we wanted to look at the incidence of kidney stones in the chlorthalidone group versus the hydrochlorothiazide group. So for those of you that weren't here last year where I went through this, I'll go through it again. So what is the diuretic comparison project? It was a large, randomized, pragmatic clinical trial that was done to compare the cardiovascular incidence of chlorthalidone versus hydrochlorothiazide. And as I said before, this is a secondary analysis of this trial. And so I just want to walk you through a little bit of the trial because I think the design of the trial figures into the interpretation of the results I present today. So when I say it's a pragmatic randomized control trial, what do I mean? So what we tried to do is we tried to make this so that it was very light touch. It was done at VAs across, so 72 VAs. I wasn't approved until an hour ago to say the word VA, so I stripped out the VA from all of my slides. So it was 72 VAs across the country. And so what we did was we did a consent through the electronic medical system. We went to the provider, said, hey, your patients are eligible. Are you interested in participating? We had the provider consent to participate through the electronic medical record. We then went and we found patients of theirs that had hypertension who were on hydrochlorothiazide. They were on either 25 or 50 milligrams. We then contacted the patients, both by mail and then by phone. There was a waiver of documentation of informed consent, so we could get phone consent from these individuals. When we called them, we got the phone consent. We then went back to the provider. So the initial one was, I want your panel. Now we say, Mr. Smith is interested in participating. Are you okay with Mr. Smith participating? Provider says yes. We randomize the patient. They're either going to stay on their hydrochlorothiazide or they get switched to a dose-appropriate dose of chlorthalidone. And so it's about 2 to 1. So if you're on 50 of hydrochlorothiazide, you got 25 of chlorthalidone. And then after that, everything was left to usual care. So the drug was filled by the local VA pharmacy like they would any other drug. The provider was told this is usual care, so it was all open label. So if the provider then said your blood pressure is poorly controlled and I want to do a dose escalation, that was permitted. They wanted to stop the drug, that was permitted as well. What we as the study did was we passively followed everyone through the electronic medical record. And so we were able to access labs, claims, outcomes, and things like that. And so the nice thing is we can now pivot and look at additional outcomes because the entire trial was designed to be EMR-based outcomes. So again, it's pragmatic in nature. So this was done at 2 sites. Minneapolis and Boston were the only places where there were study staff. So of the 72 VAs, there were no study staff at any of these sites. Everything was centralized, so recruitment, consenting, randomization, filling out the drug order, as well as assessment of outcomes. And as I said, everything was usual care after randomization. So who do we include? So I went through a little bit of this. So you had to be over the age of 65 years of age. So initially this was because we thought we would want to use Medicare outcomes. It turns out there's a new act passed and the VA pays for everything, so we get all outcomes now. You had to be on hydrochlorothiazide at 25 or 50 milligrams, and you couldn't be on a combination drug just because it would be messy then to convert you. You had to have a blood pressure of at least 120, and so we're guessing at the appropriate dose, so we thought it's a 2 to 1, but we wanted to have a little cushion in there, so we didn't want to make people hypotensive. There were no EGFR inclusion or exclusion criteria, so we took everybody. And so, again, it was open labeled, and the patients were randomized to either remain on their hydrochlorothiazide, so again, they were on hydrochlorothiazide to begin with, or get switched to chlorthalidone. For this analysis, our primary outcome was the time to the first kidney stone that developed after randomization, or until withdrawal, death, or end of follow-up, which was June 1st, 2024. Our secondary outcome was recurrent kidney stones. So again, these are subsequent stones after randomization that are greater than 6 months based on claims from their first stone. And we looked at some safety events, again, as hypokalemia as the predominant safety event. All right, so this is a complicated slide. So I'm just going to walk you through it. So we randomized about 13,500 individuals into the trial. So again, chlorthalidone versus hydrochlorothiazide. And so it was 6,700 chlorthalidone and about the same number who were on hydrochlorothiazide. And we're going to do a subgroup analysis in here. So I'm going to show you the flow diagram for the subgroup analysis. So the vast majority of individuals had no history of kidney stones at baseline. So you can see of the 6,700, about 6,200 didn't here, 6,700 here, another 6,200 didn't have it. And about 1,000 people between the two studies had a history of kidney stones. So again, you can see the breakdown of it. You can see over the trial of these people without a history, 319 had a kidney stone. Of these 1,100 individuals, you can see, again, once you have a kidney stone, you're much more likely to have a kidney stone. So the incidence here was much greater. And then you can see recurrence here in this population of the 319, 83 had an additional event. And here it's in about 50% had an additional event subsequent to that stone. Here are the baseline characteristics. It is a VA population. So you can see they're elderly. They're predominantly male, so 97% are male. If you look at the race breakdown, you know, the nice thing about doing a pragmatic trial is we can recruit from around the country. So we are in Puerto Rico, Alaska, Hawaii, where traditional trials are unable to go. And so we are highly representative of the US population. So about 15% are Black. You could see rural areas, 45%. So, and of those, about 1.5% are highly rural. These are individuals who are typically never enrolled in clinical trials. You can see, I thought smoking was done, but it turns out about 23% of people still smoked. The vast majority of individuals were on a low dose of their hydrochlorothiazide at randomization. Diabetes was highly prevalent. You know, we can go back and look. It's about 12%, 12 to 13% had gout at baseline. If you look at hypercalcemia, it's about 1.5% had a history of hypercalcemia by labs at baseline. History of kidney stones, I showed you before, it's about 8.6% at baseline. And then hyperparathyroidism, it's about 0.9% at baseline had a history of hyperparathyroidism. And then you can see the baseline creatinine is about 1.1, so relatively low incidence of CKD. So overall, no difference in the time to the first kidney stone following randomization. You can see here the hazard ratio is 0.98 and the p-value is non-significant. But again, you would expect that because the vast majority of people in this aren't going to just develop a de novo kidney stone. It's a low risk population. And so here's the outcomes again, just for the overall. You can look at every event here. So overall percentage with kidney stones, no difference. The number of stones per patient, no difference. If you look at recurrent stones, again, no difference between the two drugs. Hypokalemia, as we've demonstrated, I think in every other analysis we've looked at, because it's the same population, individuals on chlorthalidone have more hypokalemia, so about a 2% absolute greater risk. And how do we define hypokalemia? So there's two ways here. So if you look at the hypokalemia as the primary cause of hospitalization, so it's borderline significant. Again, for a safety outcome, I would call that significant. And if you look at a serum potassium less than 3.1, again, a 2% higher absolute incidence of a low potassium in this population. So what if we stratify? So we stratified by baseline history of whether you've ever had a kidney stone or you don't. So the first thing you want to look at before we stratify, is there a P for interaction? So we have a highly significant P for interaction over here. So the P for interaction here is 0.005. So again, so that suggests that the treatments are different, whether you have a baseline kidney stone or you don't. And you can see what the differences here is. So again, so these are the individuals with no history of kidney stones. Again, so it's a very low incidence of kidney stones going forward, and there's no difference between the two drugs. I think the thing that surprised me, if you were on chlorthalidone, you had a 25% increased risk of having a kidney stone following randomization compared to if you were on hydrochlorothiazide. And that's statistically significant. So you have a significant P4 interaction and you have a significant subgroup analysis effect. So let's take a look at a little more detail here. So if you look here again, so all the action is here in those individuals with a history of kidney stones. So if you look, so this is not time to, this is just a count. So it's the time to is what I showed you before was significant. If you look at the number of stones, there's a slightly greater number of stones. Again, if you look at the no history of kidney stones, it's about the same. Recurrent kidney stones, you can see, I don't know how to interpret that. That's a p-value, I think it's statistical noise. But if you look over here, a greater incidence of recurrent, again, so an additional kidney stone. So it's a weird way of saying incident and recurrent in a population with a history of kidney stones, but I couldn't come up with a better way to do this. Multiple stones here, again, more common in the chlorthalidone group than in the hydrochlorothiazide group. Again, hypokalemia, 2% absolute change here, 2% absolute change here. If you look at primary cause of hospitalization, very common here, very common here. It's about the same level. You know, the question is well, why is this the case? I don't know. Again, I think chlorthalidone should have reduced the risk of kidney stones based on the prior data, though if you look at the 24-hour urine calciums. I think the thing that people don't recognize, the more I do this, the more I'm convinced hypokalemia is the root of all evil. And so if you look, hypokalemia reduces citrate in your urine also, and I suspect it is again, this is hypothesis generating. I don't know why. But I suspect it's related to the hypokalemia, reducing citrate in your urine. And as a result, you have an increased risk of kidney stones. And so what happened to the potassium? So if we look at prescription, so the nice thing is, you know, the VA, we are also their pharmacy. So not only do we have the prescription, but we know if they filled it. So here are the fills for potassium prescriptions over time. And you can see here, so again, so the black lines are chlorthalidone, so no history. Here is the dashed line. Both populations, if you're on chlorthalidone, you got more potassium over the course of the trial. What type of potassium did you get? Well, it turns out you got a little bit of everything, but the vast majority is potassium chloride. And again, if you were on chlorthalidone, you got more than if you were on the hydrochlorothiazide of potassium chloride. And the question is were people paying attention? You know, you could also use potassium citrate. And if you had a previous history of kidney stones, were you more likely to get potassium citrate? And it turns out, after a while, they figured it out. And so initially, they said, no, we don't care. But then after a while, after you kept getting stones, it looks like somebody started paying attention, and we started to use much more potassium citrate in the chlorthalidone group compared to the hydrochlorothiazide group. What about other drugs for kidney stones? So there's this question of could you have increased the risk of uric acid stones with chlorthalidone? So if you look at other observational trials, chlorthalidone increases your risk of gout. It increases your risk of uric acid stones. It looks like individuals on chlorthalidone had an increased risk of increased usage of allopurinol as well over the course of the trial, but again, only in the kidney stone group as opposed to the non-kidney stone group. And then what about it? Everybody wants to know, what happens to SGLT2 inhibitors? So again, so this is a trial that was done prior to the widespread adoption of SGLT2 inhibitors, but you can see over the course of the trial, there is rapid adoption from about 2% here to about 16% at the end of the trial, but generally no difference between the chlorthalidone group and the hydrochlorothiazide group. So overall, secondary analysis of the diuretic comparison project, which was a large pragmatic clinical trial. If you look at the overall study, there was no difference in incidence of kidney stones between chlorthalidone and hydrochlorothiazide. Again, I would argue that's probably not the right comparison. I think we would want to look particularly in those with a history of kidney stones. And then there's this unexplained 25% increased risk of subsequent claims for kidney stones in the chlorothalidone group compared to the hydrochlorothiazide group. Why is that? I'm not quite sure. Again, my hypothesis is it's the hypokalemia. I think one thing we can look is specifically, so this is a randomized evaluation. We can look in an as-treated population and look specifically in those who have hypokalemia and their risk of then developing kidney stones, which is something we're going to do. So what's the take-home message? So Bill Cushman is my co-chair on this study. He loves chlorothalidone. I've never seen anyone who loves, I used to love chlorothalidone also. I am now much less likely. So one, it doesn't come in a combination pill, right? I think you should use a combination pill for everybody. Number two, I am now convinced hypokalemia is trouble. And if you're going to use chlorothalidone, pay attention to the potassium. Sometimes I use chlorothalidone preferentially in people who get hyperkalemia on an ACE inhibitor. That's a good drug. It causes lots of side effects that I want to take advantage of. But in general, I'm now trying to use more hydrochlorothiazide, unfortunately, which is not where I started when I started the trial. I'll open it up for some questions. So thank you very much.
Great. The diuretic comparison project is open for questions. We have a question here.
Thank you for that presentation. Have you compared chlorothalidone with indapamide?
We haven't. So we had, you got one bullet when you're going to enroll 13,000 people. And so we picked chlorothalidone. I think that's the predominantly used drug in the US, which is where we're based. And so I think the unfamiliarity with indapamide would have made it difficult to do.
Okay, thank you.
Any comments on the practical use of chlorothalidone in terms of, at least where I practice, the 12.5 milligram dose is difficult to find. So any approaches that you suggest?
So as I said last year, I'm always astonished about clinical inertia. So it's good if you're doing a trial at the VA, because once we start it, nobody ever stops it. But the other thing that happens that I don't understand, so the mean blood pressure at the start of the trial is 139 millimeters of mercury. And we switched people from 25 of hydrochlorothiazide to 12.5 of chlorothalidone. That dose doesn't exist. And so we asked everybody to split their pill every day. So every day somebody's taking chlorothalidone dust, because it's a tiny pill, it doesn't split well. And so you take a little bit of dust today, take a little bit of dust tomorrow. And it would have been easy for anybody at any time to say, take the whole pill, because your blood pressure is 139, we want it lower. But nobody said that, right? They all just said, keep with the dust. And so I would say, again, so a take-home message is if someone is on 25 of hydrochlorothiazide, a secret dose escalation is to switch them to 25 of chlorothalidone. You get the dose escalation with the same one drug, one copay. It's easy switch to make.
Great, thank you.
Yeah, lovely presentation, Lafayette, Stanford. So just really want to push you on this because, again, you're looking at a trial not designed to look at this. You're looking at a secondary analysis, and then you're looking in a tiny subgroup of 1,000 patients in a field where we're not sure thiazides affect stones and where the difference between chlorothalidone and thiazide has vanished in other fields for hypertension and heart failure prevention. So how strongly do you really want this audience to walk away and think that there's a difference in terms of stone recurrence? And should they even worry about whether they're writing thiazide or chlorothalidone these days?
So that's a good question. So yes, so the overall trial, negative. So there's no difference between chlorothalidone and hydrochlorothiazide. We've looked at a number of outcomes, so cardiovascular outcomes, no difference. Renal outcomes, no difference. This stone thing, maybe a difference. So if you walked out of here that there's no difference, okay, that's also, that is, I think, the take-home message. However, if there's no difference, then you can pick either one. And if you've got a stone patient, you might want to pick the one that suggests that they're having fewer stones. There is still the question of whether it's better than placebo. That's not this question. But based on the results of this randomized subgroup analysis, chlorothalidone appears to increase the risk. And so why would you pick a drug that you say, at best it's the same, but here's a subgroup analysis where it might be worse, and it's definitive that it does cause more hypokalemia. I think if you look at the main trial results, hospitalization for hypokalemia was much more common in the chlorothalidone group. So I would just, even to avoid that side effect, ratchet down the use of chlorothalidone.
All right. So commend you on a really amazing study. The first question I had, did you enter the data on 12,000 people?
So I showed you the team there. I got to tell you, so they made 70,000 phone calls to randomize the 13,500 patients. So they did a phenomenal job. I called zero patients.
Just a quick comment. I mean, the VA system may be the perfect system to do comparator studies where you take away cost motive and start looking at some of these everyday questions that we all deal with. That'd be terrific. I have a little bit different question for you. You may have said it, maybe I missed it, but you said that there was no difference in the gout. But did the long-acting chlorothalidone increase your level of hyperuricemia? I'm one of those people that believe that hyperuricemia really means something, and I was curious about that.
So if you look at the observational studies, so from insurance databases, there's a couple of these. It increases the risk of gout compared to hydrochlorothiazide. When we look here in the DCP, which is again a randomized control trial, there is no difference in uric acid. But remember, it's only a subgroup of the population that got uric acid measured. And we also looked at gout and things like that. There's no difference, at least in our study, in the incidence of gout between the two drugs.
Yes, thank you.
Just want to know if next year in New Orleans we'll be seeing the bone and fracture data.
You called it last year, and so here we go.
Thank you. There's a question from the poll, I guess just to level set. Can you discuss the blood pressure differences in the two groups?
Yeah, so there were no, the question is did we guess right? And there's two ways you could try to figure this out. So one is, should we have guessed right on the potassium? And we guessed that chlorothalidone at a higher dose, potentially. But the second way to look at it is your blood pressure. And if you look, I didn't include the blood pressure data, but it's in our primary manuscript. The two lines are superimposed at every time point over the course of the trial. And so I think we guessed right on the dose of the thiazides, and so the two were equivalent.
Other questions? Thank you for your attention. Thanks for a great presentation. Data Comparison Project. Ari Fashani.